the work we are presenting here at ASCO is work from the RANO consortium, which is the Response Assessment Neuro-Oncology consortium. And we are presenting data on behalf of the RANO resect group, which is our group which really focuses on surgical issues within that RANO framework. And we are currently dealing with the prognostic value of surgical re-resection in recurrent glioblastoma. So when we think about a glioblastoma, which is the most frequently encountered primary brain tumor, standard of care in the primary situation is pretty much predefined and consists of surgical resection followed by standard of care radiochemotherapy. However, when we think about the recurrent situation, and progression always occurs in glioblastoma patients, the therapeutic approaches which we use dramatically vary because there is no randomized controlled trial showing superiority of one treatment approach over another. So what we aimed is to establish the value of surgical re-resection previously resected glioblastoma patients. So what we did was we accumulated the clinical data of about 680 patients with an IDH-wildtype glioblastoma, so diagnosed according to the current WHO 2021 classification system. And we stratified patients according to whether they underwent re-resection or no re-resection. And those groups were pretty much equal in terms of patient size, about 310 patients who underwent re-resection, 370 patients who did not. And there was no difference in terms of demographic markers and clinical markers, including first-line treatment, but also extent of resection, the primary situation between those two groups. And when we stratified outcome according to whether patients underwent re-resection or no re-resection, patients who underwent re-resection did dramatically better compared to patients who did not undergo re-resection. There's a lot of confounders to be considered in that situation, and those findings still hold true when controlling for those confounders in a multivariate analysis. But we even added another level of granularity by controlling also for the residual contrast and non-contrast enhancing tumor volume using the so-called RANO classification system for extent of resection in glioblastoma. And what we found was that only patient in which almost no residual contrast enhancing tumor volume is being left behind, only those patients seem to have benefited from surgery. And second, there was surprisingly no value of going beyond the contrast enhancing tumor margins, so we did not find evidence that patients within the group supramaximal resection did better compared to patients in which only complete resection of the contrast enhancing tumor volume has been provided. And why was that so? So when we looked into the outcome of patients according to which kind of treatment they underwent following surgical re-resection, we found that patients which had chemotherapy after surgical re-resection did best compared to patients in which re-irradiation was provided or surgery only. Interestingly, patients in the surgery only group had the highest rate of new deficits, and so also did patients in the group which we entitled supramaximal resection beyond the contrast enhancing tumor margin. So it's very tempting to speculate that patients in the supramaximal group had the highest number of deficits and were prohibited from undergoing further medical therapy, which might have counteracted the potentially beneficial effects of surgical re-resection. So I think our current study really shows three important things. Number one is it's the contrast enhancing tumor volume, which really matters when surgical re-resection is applied in the recurrent glioblastoma setting. Number two is that it's the RANO resect classification system may stratify patients accordingly. And number three is that if you go within the surgical resection beyond the contrast enhancing tumor margins, it's most important to not induce a new deficit, because this may prohibit patients from undergoing further treatment and may counteract any beneficial effects of surgical re-resection.